You guys see me in the back? I feel like I need a platform or something.
Just walk over here.
Brian wants me to ask who are the chiropractors here tonight, if you can raise your hand. Okay. He feels embarrassed he didn't ask that, so thank you for being here. Okay. My name is Jonathan Lee. I'm a spine surgeon here at Maxim Spine. Just thank you guys for being here. I know it's a night out you could have been at home or with your family, so we appreciate your time. So this talk is not about how to send every one of your patients to have surgery. It's really about timing, when continuing conservative care helps, but when also escalation can be just as important. So everyone knows who this is. This is Tiger Woods. He's one of the greatest athletes known in modern sports history. He revolutionized golf with his athleticism, his dominance, his mental toughness. He won 15 major championships and 82 PGA titles, which is tied for the most in history. However, his career was really riddled by a lot of injuries. And he's forcing him to have many setbacks in his career, which really reshaped his body and the trajectory for his career. Specifically, in the mid-2000s, he started dealing with a lot of mid-back pain, lower back pain. He treated it conservatively for a number of years, but then was forced to have his first lumbar surgery in 2014. So this is a timeline of his back pain. Really, in his early career, he had intermittent low back pain, treated it conservatively, played through the symptoms for years. This back pain transformed into radicular pain down the legs. He ultimately ended up having one lumbar surgery in 2014, followed by 3 more, until his triumphant return in 2019. In 2019, he won the Masters, which was his 5th Masters title and his 15th PGA championship. And this is even more impressive given the fact that he just had these 4 major lumbar surgeries. It was his first major first major win in 11 years, and it is highly regarded as one of the strongest comebacks in sports history. And Tiger Woods is an extreme example. My point is not that if you have spine surgery, you're going to be an amazing golfer. My point is that Tiger's story really illustrates how sometimes it's really difficult to know when a patient has really crossed that line from being able to manage their symptoms conservatively versus when they have to manage their symptoms with a surgical referral. And referral doesn't always mean surgery. I think really referrals really mean guidance. It's recognizing when their trajectory really isn't improving with conservative care, and when a surgical referral can really help patients in the long term and might be able to even save themselves from having surgery. So in that case, you are the gatekeepers, and a good gatekeeper knows when to hold the line and when to open the gate. And when I say you all are gatekeepers, I really don't mean that you're blocking care. I mean that you're really guiding it. And you're the first to know when patients' symptoms worsen. You're the first to know when their function declines. And you're also the first to know if a patient develops some neurologic signs or symptoms, which is very important to refer. I worked really hard on that slide, so. So Scott kind of mentioned this. I will piggyback off of this. So some absolute referral triggers. Progressive motor weakness in any part of the body is definitely a referral signal. I was talking to someone earlier, but specifically progressive weakness without any pain is actually a red flag. A lot of patients who have progressive weakness without pain kind of shove it off and don't seek care, or maybe their conservative care guides don't really notice that they're not in pain but have this progressive weakness. But it's really important for patients to be referred if they have progressive weakness in any part of their body. New foot drop or hand weakness is pretty obvious, but a foot drop can be significant for a lumbar spine pathology, specifically the lower lumbar nerve roots. It can also be a peripheral problem. In either case, it's important to have a referral for that. Myelopathic signs, specifically point to problems in, regarding the spine, the cervical spine, and the thoracic spine. Any patients that complain of balance issues, numbness, tingling, weakness in the hands. A lot of patients may complain that they're losing dexterity in their fingers, or they can't hold utensils well, they can't write as well anymore. They write really scribbly. That's signs that could lead to point to myelopathy. Bowel and bladder dysfunction is an obvious one, can be a sign of impending cauda equina issues in the spine, which is also important. And saddle anesthesia, if you imagine you're sitting on a horse, any part that's touching the horse, if you have some sort of numbness there, tingling in that area, it's very important to refer those. Any questions on these type of symptoms, which Scott kind of mentioned? So that leads to these relative referral triggers. I think that this is sort of a gray area where you're not sure if you should continue seeing patients throughout their pain, or when it is safe to see them for a few more sessions before you refer. And I admit that I recognize that it's very difficult sometimes to figure out when a patient should take that next step, and maybe you don't want to seem too pushy towards a patient and tell them they need to see a surgeon, and you don't want to seem like your therapy isn't working or so forth. So it can be difficult at times, but I think that this is a good guideline. Any axial radicular pain that's really not improving after 6 to 8 weeks of PT, I think is very important. Pain at rest is also a big red flag. I think it's understandable if patients initially have pain whenever they're walking or playing a sport or running or so forth, but if they tell you repeatedly that they're at pain even when sitting down, they can't eat dinner, or they can't wash dishes without pain, I think that's also a red flag where a referral is indicated. Any worsening pain despite weeks of mixed conservative treatment. If they've had weeks of physical therapy, chiro, they've gone to a bunch of pain management doctors, I think it's also pretty safe to refer in that case. And any recurrent flares with regression, and it's difficult because I know patients, some weeks may say, I'm doing great, I'm doing better, and other weeks they may say, they're not doing so great, and it fluctuates. Any patient that really has that fluctuation, I think it's important to refer. Okay. And, on that line of referrals, I think it's important, and I think a lot of you know this, that when you refer a patient to our practice, we're willing to see any patients whether or not they're surgical or not. So you don't need to tell us whether you think they're surgical or you think they need this type of surgery. Really willing to talk to any patients that are just interested in their symptoms in itself. I would say the majority of patients we see are really non-operative, but we really like to be the quarterbacks and lead them to the right conservative treatment. And a lot of times we send them back and say, you're not a surgical candidate. I don't think you need surgery. I think you're doing the right thing. Continue to go into therapy. So I don't want patients to think that be scared of seeking out a provider for a surgical consult. So, I don't want to seem like we're, too greedy. So some of these symptoms, I would say it's okay to monitor and to escalate if worrisome. Repeated symptom reproduction with specific movements. I think, for example, if a patient says, every time I play golf, my back hurts. I think that's okay to monitor, specifically with axial pain. Unilateral symptoms with dermatomal consistency. A lot of patients who have radiculopathy, it can be subtle, but if it's not too severe, some patients can be just symptomatic from the smallest disc bulge. And a lot of you providers have patients who have radiculopathy, and with really good therapy with conservative treatment can be treated successfully. Any symptoms migrating distally over time. I think that this can be a sign to refer your patients to us or to continue treating them. I think this is also a gray zone. And strength asymmetry that doesn't normalize, it's also okay to monitor, but if you get into the territory of really severe weakness, I think it's important to refer. I would say one rule I really have is progressive neurologic change or failure to progress despite appropriate PT or chiropractic work. It really should be a referral. And I tell all my providers that and colleagues. Any questions about that? Okay. So, we really like to be collaborative. I would say I'm, good friends with all of my, colleagues that I've interacted with, and I, love to share my phone number. I love to text and call with any provider. So I really love it when you give me a summary of your patient referral. I have a lot of fans out there. For example, I am a big texter. They were just making fun of me for being on my phone all the time. So if you send me a text with a referral, I'd be happy to speak with you. It's helpful if you tell me specifically what you're concerned about, what their symptoms are, when the onset was, the progression of the timeline, specifically what type of movements seem to be bothering them, whether it's flexion or extension or a row machine or anything. I would think that would be very helpful. And what specific exercises seem to exacerbate the problem. Any questions about that?